Thomas Januškevičius, urologist, Institute of Clinical Medicine, Faculty of Medicine, Vilnius University. We'll talk about DNA damage repair, gene mutation, and liquid biopsy in prostate cancer. So, please, Thomas, you can start.
So, hello, dear colleagues. Today, I'm gonna talk about DNA damage repair, gene mutations, and liquid biopsies in prostate cancer. Thank you for the opportunity to participate in this year's EBU training. And let's start. So, according to Globacon, prostate cancer is the second most frequent cancer in men. Age, family history, racial and ethnic background are the main risk factors of PCA. Radical treatment with curative intent provides good oncological results for localized disease. However, 4% of PCA patients develop metastasis after primary treatment. So DDR pathway is critical for the integrity protection of the genome. DDR deficiency as an underlying cause for genome instability and mutations in tumors has been recognized as one of the hallmarks of prostate cancer. In prostate cancer, genomic instability and chromosomal rearrangements are common, and DDR pathway impairment can be detected in a considerable fraction of cases. It is more prevalent in CRPC and is highly enriched in metastasis. So, if DNA damage correctly repaired, there will be no consequences. Without repair or insufficient repair due to defects in DDR genes, cell death is most common fate. Unrepaired double-stranded DNA breaks are lethal. It can result in accumulation of DNA damage in the form of mutations, and it will be resulting in cancer cells may be more susceptible to drugs that are inactive remaining DNA repair pathways. Recent data suggest that up to 12% of PCA patients with metastatic disease may harbor germline mutations in non-androgen receptor-related pathways. Inactivation of DDR pathway, including mutation in genes, plays a significant role in carcinogenesis. Pathogenic germline variants in DDR genes can increase the risk of more aggressive form of PCA disease. So cancer cells can accumulate DNA damage, and poly-ADP ribose polymerase, usually called PARP inhibitors, work on the theory that cancer cells accumulate DNA damage as they are dividing. There are two ways that a cancer cell can fix DNA damage. The first is called base excision repair. This is a way that the cancer cell can fix single-stranded DNA damage, and the main protein PARP help in this situation. The second way that a cancer cell can fix DNA damage is called homologous repair, and that primarily fixes double-stranded breaks. So if a cancer cell doesn't have the ability to fix a double-stranded DNA break, a form of DNA damage, because it has a mutation in a gene that codes, for example, BRCA1, then its homologous repair function is compromised, and the cell can rescue or recover from the unrepaired DNA damage by using the PARP enzyme as a second option to fix the DNA breaks. The PARP inhibitors work based on a concept called synthetic lethality. It means you are now using a drug that inhibits the cancer cell's other mechanisms by which it can repair its DNA damage when one form of DNA repair is already compromised. So how can we get information nowadays? Blood, urine, saliva, or other body liquids can be used as liquid biopsies to detect DDR mutations. It helps expand access to important genomic information and can be used to find somatic and germline mutations. It becomes a part of routine clinical cancer care. Comparing to standard biopsy techniques, a liquid biopsy is quick, minimally invasive, easily obtained, and has a minimal risk or pain. What about guidelines? European Association of Urology recommends yearly PCA testing for men carrying BRCA2 mutations and for patients which are older than 40 years of age. Until 2021, PARP inhibitors or platinum-based chemotherapy were still unapproved, but were considered for mCRPC men with DNA repair deficiency. Although the level of strength rating is weak, in 2021 EU released an update in prostate cancer germline testing. Now clinicians should consider testing in men with metastatic PCA, men with high-risk PCA who have a family member diagnosed with PCA at age younger than 60 years, also in men with multiple members diagnosed with PCA at age younger than 60 years, or a family member who died from PCA, or in men with a family history of high-risk germline mutations, or a family history of multiple cancers on the same side of the family. I need to note that genetic counseling is required prior to germline testing. Yet the patient is metastatic with castration-resistant TACE. There is strong recommendation for somatic and or germline molecular testing, as well as testing for mismatch repair deficiencies or microsatellite instability. So, which mutations must be searched? It is not specifically defined yet by you, but according to the multiple studies data, the EU indicates that BRCA1, BRCA2, ATM, CHEK2, HOXB13, and mismatch repair genes can drive the development of aggressive prostate cancer. So, what about American Society of Clinical Oncology? By ASCO, patients with metastatic prostate cancer are recommended to be screened for BRCA and mismatch repair gene mutations. An ATM gene test should be considered, as well as tests for NB, PALP2, and other genes showed in the picture, when there is a positive family history. In non-metastatic prostate cancer, it is recommended to perform only BRCA2 screening. ATM is also considerable, as well as other genes when there is a positive family history. All men with a positive family history without a diagnosis of prostate cancer should be tested for the genes BRCA2, HOXB13, and for other genes it should be a considerable choice. Patients with BRCA2 mutations may have response to PARP inhibitors. For those with BRCA1, PARP inhibitors must be considered. Also, BRCA carriers must be considered for platinum-based chemotherapy, and after progression on abiraterone may consider PARP inhibitors rather than taxane. National Comprehensive Cancer Network guidelines recommend that at the time of initial diagnosis of prostate cancer, clinicians should inquire about family and personal history of cancer. The NCCN recommends germline genetic testing for patients with prostate cancer and any of the following: a positive family history of cancer, high risk, very high risk, localized, regional, or metastatic prostate cancer, regardless of family history, Ashkenazi Jewish ancestry, and it should be considered when we have introductal histology or a personal history of breast and other mentioned cancers. Germline testing at least should include the following: BRCA1, BRCA2, ATM, PALB2, CHEK2, and mismatch repair genes for Lynch syndrome. In May 2020, the FDA approved olaparib and rucaparib, which are also included in NCCN guidelines for mCRPC patients. So olaparib is a treatment option for patients with mCRPC and pathogenic mutation in at least one of 40 genes. Patients must be previously treated with androgen receptor-directed therapy. Rucaparib is a treatment option for patients with mCRPC and pathogenic BRCA1 or BRCA2 mutation. Patients must be previously treated with androgen receptor-directed therapy and a taxane-based chemotherapy. But I need to note that if the patient is not fit for chemotherapy, rucaparib can be considered even if taxane-based chemotherapy has not been given. So, as it mentioned earlier, inherited DDR gene mutations are relatively prevalent in patients with mCRPC, but their clinical importance for the treatment of the disease needs further analysis. I would like to show you an important studies in this field. Anala et al. In 2017 analyzed more than 300 mCRPC patients. They found that of the 319 patients in the study, 24 had deleterious germline mutations, with BRCA2 being the most frequent. Here you can see a swimmer plot where yellow dots are ADT initiation, red mCRPC diagnosis. It shows that median time to development of the castration resistance following ADT initiation was shorter in patients with germline DNA repair alterations, comparing to germline mutation negative patient group, almost 12 months versus 19. Anala also reported that median time to PCA progression on first-line abiraterone acetate or enzalutamide was also shorter compared to germline mutation-negative patients. For patients receiving chemotherapy as their initial therapy for mCRPC, the median PCA progression-free survival was 7.2 months in germline positive group, suggesting that chemotherapy sensitivity may be retained in these patients, but there was no statistically significant difference between groups. Anala findings to be in conflict with another recent publication by Antonorakis, suggesting that mCRPC men with DDR gene defects may have superior response to the first-line novel hormonal agents. Antonorakis concluded that the outcomes to the first-line novel hormonal agents appear to be better in mCRPC patients harboring germline BRCA or ATM mutations versus no mutations. But these conclusions are limited by a small number of patients with BRCA ATM mutations, only 9, whereas overall mutations in the study were found in 22 patients. There was no statistically significant difference between groups. In prostate cancer, there has been a lot of excitement about using PARP inhibitors in castration-resistant patients. The first study that led to this excitement was a trial called the TOPARP-A study, which was done in the United Kingdom by Jacqueline Mattea and Joan de Bono. There were two groups, biomarker positive and biomarker negative groups. All 49 patients were treated with olaparib. They had no previous PARP inhibitor or platinum-based chemotherapy, and patients were progressed after 1 or 2 chemotherapy regimens. As you can see, 16 of 49 patients were defined as biomarker positive patients. It means they had a mutation in one of the homologous repair genes. The most common ones were in BRCA1, BRCA2, ATM, and CHEK2. 14 of 16 patients with mutations shown response to olaparib, so response rate was high, 88%. Conversely, only 2 of 33 biomarker negative patients were classified as having a response to olaparib. Radiologic progression-free survival was 3.6 times and overall survival was 1.8 times longer in patients with DDR genes compared to biomarker negative group. On a continuum, TOPARP-B was an open-label phase 2 trial that included 98 patients, mCRPC with known aberrations to 18 DNA repair genes who received olaparib. The dosage was different, and also like in TOPARP-A, no previous PARP inhibitor or platinum-based chemotherapy was used. Radiological response according to RECIST 1.1 was observed in 8 of 33 available patients in the 400 milligrams cohort and 6 of 37 in the 300 milligrams cohort. PCA 50, it's a PCA reduction 50% or more. Response was observed in 17 of 46 and in 13 of 43 respectively. With the response to PARP inhibitors differ according to the affected gene. Marshall et al. Had 23 mCRPC patients which had pathogenic mutations in BRCA or ATM, and they were included in this analysis. Olaparib was given after novel hormonal agents or chemotherapy. Figure shows the best PCA response for each patient at any time point. PCA reduction 50% or more. Responses to olaparib were achieved in 76% of men with BRCA mutations versus 0 of men with ATM mutations. Men with BRCA mutations had a median progression-free survival of 12 months compared to 2.4 months in the ATM group. Overall survival also was longer in the BRCA1 and BRCA2 cohort than in the ATM cohort. Men with mCRPC harboring ATM mutations experienced inferior outcomes to PARP inhibitor therapy compared to those harboring BRCA. Of course, I need to note that the limitations of the study include its retrospective nature with overall small sample size. Efficacy of another PARP inhibitor, rucaparib, was demonstrated in patients with mCRPC and inactivation of BRCA1 or BRCA2 genes in TRITON2 study. There were 115 patients who received one or more dose of rucaparib and had a deleterious BRCA alteration. A substantial proportion of patients achieved a confirmed radiographic response with rucaparib treatment in both blinded investigator-assessed analysis and central independent radiology review. The confirmed objective response rate for the investigator-evaluable population was 50%, and for the independent radiology review, it was 43.5%. In the overall efficacy population, 63 of 115 patients had confirmed PCA response, and median time to PCA response was almost 2 months. One of the main studies analyzing olaparib effect was PROfound. It was a phase 3 study which assessed monotherapy olaparib compared with physician's choice of enzalutamide or abiraterone in patients with mCRPC and DDR mutations. In a cohort A, 162 patients were randomly assigned to receive olaparib and 83 to the control treatment. In a cohort B, 94 patients were randomly assigned to receive olaparib and 48 to the control treatment. They were progressed after prior novel hormone agents. Previous taxane chemotherapy was also allowed. Study reported a significant improvement in median radiographic progression-free survival in patients with alterations in BRCA and or ATM. It was study's primary endpoint, who received olaparib compared with physician choice of enzalutamide or abiraterone. 7.4 months versus 6. This patient population, the interim survival also favored the patients who received olaparib, 18 months versus 50. In the overall PROfound population, a significant improvement in median radiological progression-free survival was also observed for patients receiving olaparib. So there are other studies where PARP inhibitors are analyzed as monotherapy. It's niraparib in Galahad study, talazoparib in TALAPRO-1 study. Also, PARP inhibitors are analyzed in combinations with other agents as TALAPRO-2. And there are ongoing trials such as TRITON3 for rucaparib versus investigator's choice of enzalutamide or abiraterone or docetaxel, and magnitude with niraparib plus abiraterone. So in the end, I would like shortly present our study at National Cancer Institute. Our purpose was to evaluate the prevalence of DNA damage repair mutations in patients with metastatic castration-resistant prostate cancer, and to determine the relationship between DDR status and clinical response to therapy, as well as survival outcomes. 23 patients were identified with germline mutations in the blood cells, and also 23 patients were identified with pathogenic mutations in the urine. In the urine, we additionally identified 7 somatic mutations. For the mutation analysis, we used urine samples from 139 patients MCRPC. Groups were divided into DDR positive with pathogenic mutations and DDR negative without mutations. The patients with BRCA1, BRCA2, CHEK2 shown deletion only, ATM and NBN were classified as DDR positive A group, omitting the cases with less pathogenic CHEK2 mutations. Analysis was performed by comparing DDR positive A group with DDR negative and DDR positive with DDR negative group. So mean response time to androgen deprivation therapy in a hormone-sensitive setting was 4.6 years. For DDR-positive group A patients, the mean response time was 1.8 times shorter as compared to DDR-negative patients. After disease progression to MCRPC, median progression-free survival for the first-line therapy, docetaxel or abiraterone, was 1.4 years. DDR-positive group was associated with significantly shorter progression-free survival. Also, significantly worse outcomes were registered in DDR plus A group compared to DDR negative group. Regarding abiraterone as the first-line drug for CRPC, DDR positive and DDR positive A groups were associated with significantly shorter response times as compared to DDR negative patients. And mean overall survival for MCRPC patients was 11.4 years, where DDR positive A group was characterized by reduced survival rates as the mean survival was 9.5 versus 11.4 in DDR negative group. So, conclusions and take-home messages from my presentations are prevalence of DDR mutation in prostate cancer, especially metastatic, is relatively high. We can use liquid biopsies to detect the DDR mutations. Response to the systemic treatment is inferior in MCRPC DDR positive patients. And PARP inhibitors are a unique class of antineoplastic agents that function by inducing synthetic lethality. Thank you.
Thank you, Thomas. Any questions? Any questions for? We have one question from Professor Sonata Yermolaite.
Thank you, Thomas, for your nice presentation, very nice overview of PARP inhibitors effect. Dear Thomas, I want to ask you about your clinical practice. How you practice in centers clinics in the case of familial cases? Do you send them for, I mean prostate cancer cases, do you send them for genetic consultation?
Yes, if we see that we need a genetic consultation, we send them to genetics if there are familial cases. So we need to check for mutations.
And do you send them only for selection of the treatment or for any other cases?
Unfortunately, now we don't have olaparib or rucaparib approved in Lithuania, but in the future, I think it would be opportunity not only to check this patient for mutations, but also to treat.
Actually, it is possibility to apply for a very rare disease group, and sometimes they decide to provide olaparib. In some cases, our medical oncologists can tell you. And I also want to ask you, in the case when you know that the prostate cancer patient has a DDR pathway mutation, do you treat them something differently? I mean, in the situation where you don't have PARP inhibitors?
Not actually, because we don't have PARPs in our drugs, so we can check if the prostate cancer is more aggressive or it will be more aggressive in the future.
Yeah, and actually your study already showed that they respond poorly to aberonaticetate and to other treatments. So all selection of more aggressive treatments will be prevalent in these cases.
Yes.
Okay. Thank you.
Thank you very much, Lamas. I know it is your PhD topic, so good luck for your job. Good job. So thank you.